Okay, thanks so much everyone for allowing me to present today. Good morning and welcome to Echo Rounds today. Today we'll be focusing on aortic diseases from an echocardiography standpoint. I have no disclosures. So today we'll start off with the normal aorta, looking at measurements and geometry, then a quick overview of the physiology and function of it, and then just a brief overview about how echo compares to other multimodality imaging. And then we'll touch on acute aortic syndromes and thoracic aortic aneurysms. Most of this information is from the multimodality imaging diseases of the thoracic aorta guidelines from ASC, and this version is from 2015. So the normal aorta. So the aorta consists of several segments: the aortic root, the tubular portion of the aorta, the arch, as well as the descending aorta, which comprises the descending component, and then that which reaches the abdominal aorta. The most proximal part of the ascending aorta and the aortic root involves the annulus, the aortic valve cusps, as well as some of the ostia and the sinuses of Valsalva, all of which the measurements are indicated here. This is from the European Journal of Echo from several years ago, and with standard deviations here. The tubular portion of the ascending aorta goes from the STJ all the way up to the right brachiocephalic artery, and then the arch comprises the right brachiocephalic artery, the left common carotid, and the left subclavian, right before the ligamentum arteriosum. And then everything else after that is the descending aorta. These are some of the standard measurements for the aorta. As many of us know here, the standard measurement is taken at the largest diameter from the right coronary sinus to the Valsalva. And most studies report the aortic root diameter measurements at end diastole with the classic leading edge to leading edge technique. Now, in adults, the aortic dimensions correlate with body size and sex, and we define the upper limit of normal by 2 standard deviations greater than the mean. As I mentioned, leading edge to leading edge at end diastole for the aortic measurements. And the advantages of doing this form of measurement is that there is greater reproducibility, as well as identifying end diastole as essentially the onset of the QRS. Now, this isn't always the case for measuring the aorta by other means. For example, CT and MRI, they don't necessarily use the leading edge to leading edge, and in many cases they use inner edge to inner edge. However, for echo, it's remained as standard practice to do leading edge to leading edge. So regarding the ascending aorta, again, this is the leading edge to leading edge approach, which sometimes gives larger measurements compared to measuring by a CT or MRI. And on average, there is a difference of about 2 millimeters. And this has been thought to be okay because when following aortic root pathologies or pathologies of the ascending aorta with transthoracic echo, there is thought that you really just don't want to miss important pathology in that region. So having echo overestimate perhaps the diameters relative to CT or MRI by 2 millimeters is thought to be okay overall. In terms of how the aorta functions, now the aorta is clearly the largest artery of the body, carrying blood to the entire body. There are three layers of it, beginning with the intima, and then a very thick media, the muscular layer of things, and then the adventitia. So the intima is a very delicate layer that can be damaged quite easily overall and be very susceptible to trauma. The media has more smooth muscle in it with multiple layers that allow for some tensile strength as well and some distensibility and elasticity, which really confers the main properties of the aorta overall. And then in the adventitia, there is more collagen, as well as the vasa vasorum, which kind of offers oxygenation and nutritional support to the aortic wall overall. Now, the aorta, as we mentioned, is largely elastic in nature, and it allows the aorta to accommodate a lot of pulsatile blood flow as blood is ejected from the left ventricle during systole. And then allows it to continue flowing through diastole. The aorta functions as both a conduit and reservoir, and its elastic properties allows it to really expand during systole. And so under normal conditions, the aorta can often accommodate a very large portion of ejected blood. And up to 50% sometimes from the left ventricle in terms of its stroke volume is stored in the aorta itself. And that's largely in the ascending aorta at end systole before being propelled forward during diastole for circulation to the rest of the body. And so when we're talking about distensibility and stiffness, that can be often determined from changes in the diameter itself of the aorta from systole to diastole, as well as changes in arterial pressure. So this here is imaging the aorta with transthoracic echo. So on transthoracic echo, the parts of the aorta that can be seen with a peristernal views are the ascending and descending thoracic. Our apicals give view to the descending thoracic, just beyond the chambers of the heart. And in our apical 2, we can also see the descending thoracic. In our suprasternal, we see the arch and descending as well as ascending thoracic, and our subcostal allows us to see the abdominal part of the aorta. On TEE, on the other hand, you can see the ascending thoracic in the upper esophageal long and short axis, as well as the descending thoracic and arch in the aortic view. So this here is imaging the aorta with transesophageal echo. In the first image, this is the ascending aorta in long axis at 120 degrees. In the second image, we have the aortic arch in transverse view. In our third image, we have the descending aorta in transverse view. And in our fourth image, we have the descending aorta in longitudinal view. So now that we've kind of just gone over the normal aorta and some of its views on echocardiography, we'll dive into some of the acute aortic syndromes. Not covering everything specifically in this presentation here, but focusing largely on dissection and then a couple of the other less common things. So aortic dissection is largely classified into two main groups nowadays. It's type A, type B, based off the Stanford classification. Type A is the proximal dissection, type B is the distal, and this is important in terms of distinguishing because it has management manifestations. Now, historically, we also use the DeBakey classification, and these kind of fit well into the Stanford classifications as well. Essentially, type A can be broken down to DeBakey 1 and DeBakey 2. DeBakey 1 is the ascending aorta and beyond, and DeBakey 2 is a dissection that only involves the ascending aorta and nothing more. And then DeBakey 3 is essentially a type 2 distal dissection based off of standard classification. So this is a comparison of imaging modalities for acute aortic syndromes. So by and large, I don't think anyone would argue that if someone came in with tearing chest pain that radiated to the back and some neurological deficits either in the arm or in the brain or elsewhere, a stat CTA is probably going to be the best modality, both from a convenience perspective as well as kind of just getting the information quick and upfront with very little technical expertise required in the emergency room. The CTA is highly sensitive, highly specific. You can also find intramural hematomas. You can identify the site of intimal tear very easily. The only catch is that it's not great at identifying any sort of valvular dysfunction. So for example, acute AI as a result of dissection, and that you need echocardiography for, whether that's a TTE or TEE. However, nonetheless, oftentimes if they're in acute AI, they'll be presenting clinically in heart failure as well. The TEE is really good in terms of a modality for imaging acute aortic syndromes as well. Really the only major setback is perhaps the technical expertise and availability at the time of needing to make a diagnosis. And so if this is an overnight kind of thing, then DEEs are probably just not going to be the quickest and most accessible thing to get for the patient to make a diagnosis and decide whether or not this is a type A or type B and decide on appropriate surgical versus medical management. So this here are some pictures of dissection. So in the first image here, we see a flap in the proximal ascending aorta and descending aorta. The second image shows a short axis view of a flap in the proximal ascending aorta, which really shows the true lumen and false lumen. We have an apical 5 in the third view with the flap in the proximal ascending aorta. And in the fourth view, we have a subcostal demonstrating a flap in the descending aorta. So in terms of identifying flaps overall, they oscillate and clearly move overall, and they're independent of the aorta itself. Oftentimes, it's important to see the flap in more than one view, so that you to be assured that this is not necessarily artifact or reverberations from other structures, such as a very calcified wall or calcified objects, or otherwise a catheter that might be seen in the right ventricular outflow tract. Other things that can sometimes confound things are pacemaker wires or other sort of hardware in the heart. Now, true and false lumens can often be differentiated, and in the descending aorta, the false lumen is often larger than the true lumen, and the dissection flap moves towards the false lumen in systole, with systolic expansion of the true lumen, and then towards the true lumen in diastole. So expansion of the false lumen in diastole. On Doppler, oftentimes you'll see brighter shades of red and blue for the true lumen due to antegrade systolic flow. And then in contrast, the false lumen is often slower, therefore producing softer colors overall. And sometimes the sluggish flow of false lumen can often be demonstrated with spontaneous echo contrast as well. And some people refer to this as smoke. Other things to kind of look for as well are thrombus. So with lower flow systems, particularly in the false lumen, looking out for thrombus from time to time as well. And before I move on, looking for other complications as well. So for example, pericardial effusions, dissection that has led to AI, and involvement of the coronary arteries as well. So this here is a proximal ascending aorta dissection, and this is just a clip of dissection of the proximal ascending aorta with a visible flap. So this is taken from the echo guidelines. So the role of echocardiography in detecting evidence of aortic dissection and some of the definitions of main findings. This is largely what we had just discussed about how to identify the presence of a flap, which divides two lumens, how to differentiate between a true lumen and false lumen, with a true lumen having systolic expansion and diastolic collapse. And then a false lumen having diastolic diameter increase, and then other things such as contrast, thrombus, or what's previously described as smoke. And then identifying false luminal thrombosis, any tears otherwise, and then assessing for complications, including mechanical complications such as AI, or dissection to the coronaries as well as things such as pericardial effusion, tamponade as well, that has resulted from dissection. So how does aortic dissection lead to aortic insufficiency? So AI occurs in approximately half of patients with type A dissections, and the degree to which one has dissected and has caused AI can often influence whether or not someone is brought to surgery right then and there. So there are 5 main mechanisms. So first and foremost, with dilatation of the aortic root, it leads to leaflet malcoaptation, which is seen here in image A. It can also lead to the dissection flap prolapsing through the aortic valve and diastole, seen here in C. And then other mechanisms include asymmetric dissection leading to cusp prolapse, as well as aortic annular disruption leading to flailing, and then those, of course, who have pre-existing aortic valve disease, such as bicuspid valves and whatnot. So comparing the transthoracic echo versus the transesophageal echo, as mentioned previously, the transesophageal echo is more diagnostic than the transthoracic. With really excellent sensitivity, close to 100% for type A's and B's. There are a couple of blind spots on transesophageal echo, including the distal ascending aorta and proximal arch, the cerebral vessels, as well as lower down in the celiac trunk and SMA. The transthoracic echo has about 85% sensitivity for type A dissections, but really poor for type B. It's really difficult to image lower down dissections. The role of the transthoracic echo is really to kind of screen for other things, such as other etiologies of chest pain, of the chest pain syndrome, to help rule in and rule out other things on the differential, such as acute MI or heart failure or PE or pericardial disease. And then it's also to assess for complications as a quick and convenient means to determine whether or not someone has, really significant severe AI or pericardial effusion or tamponade. So the multimodality imaging guidelines do in fact recommend CT as first line. Transesophageal echo is also reasonable as first line if it is readily available, as well as if there is technical expertise that's readily available. With the caveat, though, that there are blind spots, as mentioned, including the ascending aorta, proximal arch, as well as some of the lower down structures supplying the GI tract. The transesophageal echo is tremendously helpful intraoperatively if someone goes to surgery for repair. But again, CT is often going to be first line due to convenience, accessibility, and timeliness overall. Transthoracic echo, in summary, is second line, really looking for complications and to rule out other things that could cause chest pain. And then MRI oftentimes just takes longer and is less convenient. A reasonable modality for screening or following up with patients down the road, but oftentimes just not a feasible modality of imaging first line, and rarely is angiography used. So this here is a list of things that can mimic acute aortic syndromes. So not everything is necessarily a dissection. Things like aortitis, whether infectious or non-infectious, things like syphilis or non-infectious etiologies, atherosclerotic heart disease, previous aortic surgery, a pericardial recess, remnants of non-patent PDA, reverberations in the ascending aorta on transesophageal, in a nominate vein, as well as periaortic fat and hemiazygous sheath that may mimic an intramural hematoma. This here is a clip showing some atherosclerotic heart disease and some irregularities in the descending aorta. So lots of calcifications and irregularities. This here is a penetrating aortic ulcer, which clearly kind of flaps up. Now, PAUs are often considered to be diseases of the intima itself, so resulting from atherosclerosis, whereas the aortic dissection and intramural hematomas are fundamentally diseases of the media, so the workhorse of the aorta. Penetrating aortic ulcers can happen anywhere along the length of the aorta, but often are in the mid and lower parts of the descending thoracic aorta. It's much less common to find them higher up in the aorta, such as in the ascending aorta or the arch. Again, they're often found lower down in the aorta. They can be multifocal, and typically when it does penetrate into the media, you get a localized intramural hematoma. And if these hematomas occur, then they can lead to aortic aneurysms as well, including saccular, fusiform, and false aneurysm formation, which can obviously rupture, but again, uncommon. So in this second part of, or this third part of this talk, we'll go over thoracic aortic aneurysms, some of the clinical implications of them, and what to look out for on echocardiography as well, and then quickly touching on management of them at the very end, and the screening process that's necessary. So in terms of thoracic aortic aneurysms, again, there are three layers: the intima, media, and adventitia. In terms of where they occur, the aortic root and ascending aorta comprise the vast majority of TAAs. And then in the arch and descending thoracic aorta, roughly about 10% each. Now, the definition of an aneurysm is when there is greater than 50% increase in the diameter compared to what would be expected, an expected normal diameter for that artery in question. So let me see. Yeah. So this clip here is a clip of an aortic root aneurysm in peristernal long axis. So very clearly dilated aortic root. The aortic valve moves normally. The LV size and cavity here is normal, with some little bit of maybe concentric hypertrophy of the septum and posterior wall. So there's a list of etiologies in terms of TAAs. And, in clinic, we do see a number of these syndromes in people who we follow for aortic aneurysms and dilated roots or dilated ascending aortas. Marfan syndrome is probably the most classic one of the most common ones as well. Other things include those with bicuspid aortic valves, including those, for example, with Turner syndrome, familial TAA syndromes. There's a vascular subtype of Ehlers-Danlos, type 4, Louis-Dietz syndrome, and then aortitis, including infectious aortitis and then non-infectious etiologies of aortitis, largely things like vasculitis. The infectious things are, things like syphilis or mycotic aneurysms, and then certainly trauma and idiopathic causes of thoracic aortic aneurysms. There are a couple of subtypes, largely saccular versus fusiform. So saccular aneurysms result when a portion of the aortic circumference is weakened, and therefore you get this very asymmetric balloon-shaped, almost like a diverticulum of the aorta itself. And then with fusiform aneurysms, which are by and large way more common, they result from weakening of the aortic wall altogether, which then leads to dilatation and an increase in the circumference of the aorta, which kind of starts off narrow and then widens up and then narrows again at the end of the aneurysm. In terms of the aortic root and ascending aortic aneurysms, there are a few patterns. So the first one on top is essentially what a normal aortic root should look like in a normal ascending aorta. And then the one on the very right here at the bottom demonstrates dilatation beginning at the point of the sinotubular junction, but spares the aortic annulus and sinuses. And then the two images at the very bottom to the left here, these are images of dilatation involving the annulus and sinuses of Valsalva, as well as the ascending aorta. The most common location for this is the right sinus of Valsalva, which again can rupture and may extend to the right ventricle, or less frequently the right atrium and IVS. The next most common location is the non-coronary sinus, followed by the left sinus, and rarely do these aneurysms rupture into the left ventricle overall. So this is what essentially a marfanoid aortic root looks like, heavily dilated in the annulus and sinuses of Valsalva with this classic pear-shaped pattern. And oftentimes, one of the classic features is that the STJ and beyond often remained spared in terms of the aorta. So STJ and ascending aorta. At the time of making a diagnosis of marfanoid syndrome with corresponding aneurysm, oftentimes you get the TTE, but you also get a baseline CT or MRI, just to kind of make sure you have that multimodality correlate. And sometimes you can get an MRI to measure and document the diameters of the distal ascending aorta arch and descending segments of the aorta, which can be enlarged, but will simply not be visualized well by a TTE. In terms of following patients up with marfanoid syndrome and aortic root dilatation and aneurysms, oftentimes we'll get a six-month echo, and if things remain stable at that 6-month period of time, and they're less than 45 millimeters, without any high-risk features, including a family or personal history of dissection, then annual screening via echo is reasonable for these patients. And then those who do not meet this criteria or are higher risk can and should probably be screened more frequently, like every 6 months. Stable adults who have had many years of documented stable aneurysms can be followed every 2 years, 3 years or so. So this is essentially what I just touched on here. The only other thing that I would add on here is the post-op elective aortic root replacement patient. They do get repeat imaging 6 months post-op to kind of just establish their baseline again. And certainly all first-degree relatives should be screened via transthoracic echo, plus or minus other imaging to look for dilatation elsewhere in the aorta, because Marfan's is autosomal dominant. The reason why we image the transthoracic aorta, thoracic aortic aneurysm, is to, one, confirm the diagnosis, measure the maximal diameter, define the extent of the aneurysm longitudinally, measure the diameters of the proximal and distal margins of the aneurysm, to determine whether or not there is any valve involvement at the aortic valve level, to assess the vessels of the arch, which are often not very well visualized via echo, looking for any signs of complications such as periaortic hematoma, and then to differentiate this from dissection and to detect any evidence of mural thrombus overall. This here is another summary chart in terms of comparing multimodality imaging. Again, CT is excellent at this. It often really is first line. With contrast, you get better measurements and a better characterization of aneurysms. But one of the fallbacks is that cardiac motion can cause imaging artifacts if the CT is not gated. MRI is also a very reasonable thing. Oftentimes it's used in our younger patients. The only catch though is that, depending on where you are in this country, can be a little bit more challenging to get, and accessibility overall. Transthoracic echoes are really excellent modalities for assessing disease of the aortic root and annulus, as well as the proximal ascending aorta. However, diseases that extend beyond that can often be quite challenging. And then certainly TEEs are reasonable, but are considered third line via the multimodality guidelines, and then aortography is not used as often. Now, sometimes there has been some dispute as to what the best modality is regarding echocardiographic measurements versus other measurements. The most important thing in terms of following a patient with aortic aneurysms is to use the same modality and preferably at the same center with the same machines, to allow for the best form of comparison overall. So in terms of measurements and kind of just the outcomes and prognosis of patients with aortic aneurysms, those who have TAs of less than 50 millimeters have a 2% per year rupture rate. Those who have diameters between 50 and 59 millimeters have a 3% per year rupture rate. And then those who are beyond 60 millimeters have a 7% per year rupture rate. And then in terms of kind of just identifying what is expected versus unexpected growth in the diameter of these aneurysms, in the ascending aorta, it is expected to grow by less than 0.1 millimeters per year. They cite 0.07 millimeters per year. And then in the descending aorta, you can often have more rapid growth of close to 2 millimeters per year. So in terms of other genetic thoracic aortic aneurysms, and kind of where to find them and what to do in terms of screening, the guidelines say that for bicuspid aortic valves, we are screening first-degree relatives. Their aneurysms are often located in the root of the aorta as well as the ascending aorta. Those with Turner syndrome classically have their aneurysms found in the ascending aorta. And again, this is often associated with bicuspid aortic valves. Those with a familial syndrome of thoracic aortic aneurysms have a fairly rapid growth rate. Their aneurysms are found in the ascending aorta, and all first-degree relatives should be screened. Louis-Dietz syndrome, which classically has, craniofacial abnormalities as well, classically has aneurysms in the aortic root, in close to 50% of them. But they also have widespread vasculopathy as well. And so screening for aneurysms and vascular abnormalities elsewhere often occurs as well. And then for those with the vascular subtype of Ehlers-Danlos type 4, aortic complications can occur at a young age. So these patients are often screened quite young. And then lastly here, in terms of management, from a clinical standpoint overall, when should someone be referred for ascending aorta and arch repair? The standard cutoffs are 5.5, 5, and 4.5, with the caveat, though, that if someone has significant risk factors, then their threshold for repair is oftentimes 0.5 centimeters lower. So for those who have sporadic TAAs, or those who have bicuspid aortic valves, generally their cutoff is 5.5 centimeters. Those who have Marfan syndrome related disease, or those with familial thoracic aortic aortic syndrome with rapidly growing aneurysms, their cutoff is 5. Those with Louis-Dietz, or those who have who are undergoing concomitant aortic valve procedure, their cutoff is 4.5. And risk factors for this, whereby you might lower their threshold for referral for ascending aorta and arch repair, include a family or personal history of dissection, those with progressive aortic insufficiency, those who have rapidly expanding aneurysms by more than 5 centimeters per year, and then those with Louis-Dietz syndrome of female gender, who've been found to be at particularly high risk overall. So that's it for this kind of whirlwind on the aorta, acute aortic syndromes, as well as thoracic aortic aneurysms. Thanks so much for allowing me to chat today about this.
So thank you, Brandon, for reviewing this topic for us. It's very comprehensive and it's very, very useful. And just to mention that at St. Michael's Hospital, we do have a very now nice aortic clinic that we can refer patients to. And thanks to our colleagues, especially Dr. Peterson and Kim Connolly, Dr. Geraldine Ong, et cetera, has been working with that for us. So there's a place for these patients to go to and have an expert opinion. And just a few interesting observations. So from a historical standpoint, President Lincoln is considered to be the poster child for Marfan syndrome, as well as possibly significant aortic insufficiency. And so that's in the history of medicine. And Da Vinci is considered to be one of the first ones who described the sinus of Valsalva and also the vortex flow within sinus of Valsalva in the 1400 in his brownish and yellowish manuscript. So, be that as it may, let's open this up for questions, and I'm sure there's a lot of them because there's a lot of controversy and discussions around this particular topic. So. If not, I'll start asking a question. So, Brandon, in your reading, have you come across like the need for indexing the aorta in terms of body surface area or other methods such as body height?
When I was reading through the guidelines,
should we do that?
When I was reading through the guidelines, they did say that the aortic aneurysms are often, I think I had a slide up here.
Right.
Rather, the measurements, are heavily correlated to age as well as sex overall, and so I mean, I suspect that it probably is, important to probably index them according to body surface area, but I certainly don't have expertise in this.
Yeah, but my understanding, well, currently most of the surgeons around the world is exactly the last table that you use. They use 55, 50, 45 as the cutoff for different disease conditions. So they haven't really used in the surgical guideline or the aortic guideline anywhere, specifically using the index aortic sizes for decision making. So we did actually go for that for a while, but then if you look at our old report, we've done it for a while, but we realized this surgeons are not necessarily using it for clinical decision making. So, and then also there's some issues about adjusting for different things in terms of body surface area, gender, etc. So so that's something that we have been thinking about pushing and recommending, because someone who is 6'5", like in terms of the size of the aorta of 40, shouldn't be the same as someone who is like 5 feet, for example. I mean, it's not the same equation. So I mean, this is but on the other hand, clinical decision making is still considering the same. So it's kind of interesting, especially like people are very, very short stature, or people from Asia or things like that. So that's one topic that's always been around. So the other question that I may have is in terms of follow-up, one of the more controversial topic is how or when we should start following patients with dilated aorta, and how often. So the first question is, like, if you have a proximal ascending aorta of like 39, or those are the more difficult ones. I mean, usually 40 above, then it's fairly clear that you have to do something or follow them. But anywhere between proximal ascending aorta normal is supposed to be 34 and above, and then at what point do we start following them? And same thing for the aortic roots, because the aortic root upper limbs of normal is 38 or 40, depends on who you read. So what do you think?
Those are great questions. I think, so when I was reading through the guidelines here, and kind of just looking at the rate at which things grow, again, the guidelines don't specifically address this question either, in terms of, when to start following patients, or even how frequently to follow patients, in terms of, continuing to measure their dilatation. And they kind of give a range in terms of when to follow up. And what they were speaking more so to were those with Marfan syndrome. And for those patients who have stable dilatation after the first point of diagnosis at the 6-month mark, and then they move on to annual measurements of the aorta. And then in adulthood, if you're following someone and they're now, like 40, 50 years old, and they have stable dilatation of the ascending aorta, the guidelines said that you can reach out to 2 to 3 years even as well, in terms of following them up with serial echoes. And then kind of just going back to, I guess, kind of the biological data that was found in terms of how fast these things grow. They cited, 0.07 millimeters per year. So, just under 0.1 millimeters per year on average. So I mean, I think like any, like with anything, it's probably going to be establishing the initial rate of change. And once the clinician is satisfied that there really isn't any significant rapid rate of change, then the screening and follow-up can be spread out a little bit more. But if there clearly is evidence of rapid rate of change up front, then oftentimes probably more frequent follow-up would be indicated.
Yeah, I'll throw something out there, and just see what my colleagues think. Right now, I think, for me, because I see a lot of patients in the community side. So what I notice is there's a bunch of patients, especially patients with hypertension and older people. They have actually aorta in the range of like 38, 39, and so on and so forth. That is actually very common, and especially in older group of patients. So I don't tend to follow all of them, because then it'll be like, overwhelming and maybe unnecessary. I tend to start following them when they're 40 or above, and usually I do one the next year to make sure it's not like dramatic growth, and then because it's usually the first time I see them, and then after 1 year, if it's stable, then I tend to follow them 2 years. It's not from any guidelines, but that's something that I think is practical. In US, they tend to follow anything that is dilated. I think maybe for medical legal reasons or financial reasons, but I think in Canada, we're trying to come up with a sort of like optimal solution. So let's see what my colleagues have to think about that. And is that too liberal? Is that too conservative? And so I'm curious what everybody else does. So.
Jeremy here. If it's sub 40 and especially if they're normal size, so it's not somebody particularly small, and sub 40, I'll just recommend to the family physician in my note that they do a follow-up echo in 3 to 5 years, because even if it's growing relatively fast, it's not going to get to surgical indications within that time.
And do you follow them once a year, and after it's stable, then you follow them like still, like if it's 42, do you follow them every year, or do you follow once stable then follow every 2 years? So what do you think?
Once stable, yeah, definitely 2 to 3 years. It also depends on when. Okay. So 40 to 50 will be like every 2 years if they're stable. So often, in Excel, actually, I use it often. There's a nice feature to trend data over time. Like you can right. under the report tab, there's one, I think. No, under window, right? You can trend the dimensions, and so based on that slope, I'll make a decision on whether it's 2 or 3 years or 1 year. And then obviously what the absolute dimension is. If they're over 50, it's probably yearly. Yeah,
I tend to be a little bit more stringent once it's get to 45 and or above, because for me, the number of people in my practice about 45 is not that many, but once it's get to about 45, and certainly 50 for sure. So somewhere between 45 to 50 is a bit of gray zone. So I may do like 18 months, and then like 50 or above, I may do 2 years. Once a year. But these are again, empirical, practical, pragmatic way of dealing with it rather than the guideline. So we lack that guideline. Maybe Dr. Connolly can work on that. He's the guideline chair for CCS. I always need one of those guidelines that never been made. Okay, so just another interesting paper that came across recently was actually a Hong Kong paper. They did a POCUS study among patients in a hypertension clinic. So they used POCUS to screen patients for the aorta, and then they find out that even with POCUS, they can screen out up to about 35% of patients in the clinic who have dilated aorta and subsequently need follow-up. So just an interesting sort of like project idea that they had. So that was actually made into the news in the Hong Kong media of interest. Okay, any other comments about this topic?
Qiming, is Bob.
Very
a question about a question about the aortic root measurement. This notion of sinus to commissure measurement versus sinus to sinus, which obviously is not something you get necessarily from the peristernal long axis, but from the short through the sinus. Just comments about what's the right thing to do there to get the proper sinus measurement.
So Brandon, you want to take a crack on this, and I'll help you out.
I don't know the answer to that, to be honest.
Yeah, maybe I'll take a crack at this, because obviously we talked about this a lot in our accreditation or QI round. So basically, the standard measurement, as Dr. Howard mentioned, as well as you have mentioned, is actually the linear measurement in the peristernal long axis from leading edge to leading edge when valve is closed. This is the standard from 2015 chamber quantification. But what happened is patients often we have a specific dilated sinus of Valsalva. So sometimes the left is a lot bigger, the right is a lot bigger, and so on and so forth. So usually what we may do in the short axis, if you see like a ridiculously enlarged or like obviously abnormally enlarged sinus of Valsalva, what we would do is actually do an additional measurement, and you can actually do a screen capture of it in your reports to measure the widest dimension of what Dr. Howard mentioned. You know, is the widest dimension, because obviously, you know, the sinus are not always perfectly symmetrical in free sizes. So you can report that as well and make a note about like which sinuses is the most dilated, because then we would follow that as well. Because sometimes in AP dimension it may be like 40, but in fact one of the sinuses is so dilated it can be actually up to 45 or even larger. So I'm sure we have all seen those cases. So you can make additional comments in 2D in short axis. Is that reasonable, Bob?
Yeah, I think so. I think it's just making the point that it's not always symmetrical, and where you're measuring in the peristernal long, whether you're cutting through the right coronary sinus or whether you're cutting at the level of the commissure to a sinus, it varies from patient to patient depending on, you know, how their heart's situated in the chest, right? So you can get different numbers depending on how that's actually measured. So I guess from my point of view, the largest number is probably the most important no matter how you get it. So you probably need to look at the short axis view as well as the long, just to make sure that you're not missing something that's asymmetric.
Yep.
It's probably the major, one of the major sources of I won't say error, but major sources of differences between echo aortic root measurements and CT aortic root measurements.
Yep, because they measure in 3 dimension in the short axis, so it's different than us.
They also tend to focus more on sinus to commissural
right.
measurements.
Yep, that's right. Okay, any other comments? We're running up to 8:56. So going once, going twice, and okay, thank you.